In this lecture we're going to look at electrolytes and water balance. So we'll start with water and water loss and water accumulation such as an edema. We'll move on to sodium and potassium and calcium, and then as part of the calcium component of this lecture we'll look at the metabolic bone disease and osteoporosis. As soon as we start talking about water in the body, we have to start thinking about the compartments where the water is within the body. And that means we need to think in terms of the intracellular spaces, the interstitial spaces, and the plasma volume that is part of the vascular volume. So you'll notice on the diagram on the left, which is our pie chart, the extracellular fluid, that is all the fluid that is outside of cells, includes the interstitial fluid and the plasma. There's about 3.5 litres worth of plasma and about 10.5 litres worth of interstitial fluid. Whereas the fluid that is inside our cells, that intracellular fluid, makes up about 28 litres worth of fluid. And of course the fluid is moving between these spaces all the time. On the diagram on the right, it's showing us about intakes and water losses. So just drinking water certainly puts the majority of fluid into our system. There is some fluid within the cells of the food we eat. And then of course the process of breaking that food down actually creates water as a byproduct. And so about 10% of the water that's in our bodies is actually gained through us breaking down our food. So water gained from metabolism. We lose it through the kidneys. Urine, about 60% of the fluid we lose each day is through the kidneys, but we also lose some by breathing it out as water vapor when we exhale. We lose some through the skin as part of sweat, and we also lose some through feces. So the water component in the feces that is attracted into the feces by the amount of fibre in the feces keeps the feces soft enough for us to actually pass them. Now if you see the word oncotic, think osmotic. It just depends which book you pick up, and sometimes they'll refer to it as oncotic pressure, other times they'll talk about osmotic pressure. When we're talking about capillary osmotic pressure, we're referring to the osmosis process. That means water moves across membranes in order to dilute whatever is the higher concentration. Now in terms of capillaries, the albumin protein that is in our plasma is a big molecule. It doesn't leave the plasma because it is a big molecule, and that means because it is always present in the plasma, it acts to draw fluid from the interstitial spaces back into the vascular volume. Our liver is responsible for making that protein, so that if we have problems with liver failure or liver diseases, then we can see the albumin production drop off, and that can then lead to fluid not being pulled back as easily into the vascular space after it's left it, such as in a reaction like inflammation, or simply moving fluids out with their nutrients in order for cells to pick up glucose and oxygen. That fluid has to be able to come back into the vascular space, and the osmotic pressure facilitates that. The pressure that pushes the fluid out of the vessels into the interstitial tissues and across to the cells is the blood pressure, so the capillary hydrostatic pressure. And we lose more of it out into the tissues in a reaction such as inflammation, because in inflammation we increase the vessel permeability so that more fluid can move out than what would normally move out into the tissues to facilitate inflammation. Now those pressures are opposed, that fluid movement out from the blood volume out into the tissues is opposed by the fluid pressures that are already there. So the interstitial hydrostatic pressure is the pressure on the outside walls of the capillaries due to the fact that there's fluids in the interstitial space. And there is other things like proteins and things sitting in the interstitial fluid that create a certain amount of osmotic pressure in the interstitial space, but it's much, much lower than that of the capillary osmotic pressure. But there's also numbers on this so that you can see how things are moving up and down as we move from the arterial end of a capillary bed to the venous end of the capillary bed. And as they classically do these things, the arterial end is coloured red and the venous end is coloured blue. You'll also notice there's a lymphatic vessel at the top of the screen, and any fluid that can't get back into the vascular volume drains back into the lymphatic vessels and is eventually returned to the venous blood supply. So if we block the lymphatic vessel, we'll force fluid to stay in the interstitial tissues, and that fluid's other mechanism of getting back into the venous supply is only through the osmotic pressure. So if we look at the numbers looking at this now, we can see at the left hand side of the screen we have a blood pressure that is about 35 milligrams mercury. So that's the pressure of the blood against the walls. The osmotic pressure within the blood capillary is only around 25 milligrams mercury. So that means the hydrostatic pressure is exceeding the osmotic pressure created by albumin in the blood, so that fluid will move out into the interstitial tissues. As we move across into the venous end of the capillary bed, that blood pressure has dropped and it's gone from 35 milligrams mercury down to 17 milligrams mercury. But notice, because the albumin never left the capillary fluid, the blood, the albumin stayed there, the osmotic pressure stayed the same. At the arterial end it's 25 milligrams mercury, at the venous end it's 25 milligrams mercury. And that then means that the fluid that has moved out into the tissues is drawn back by that osmotic pressure. In order to maintain the concentration of the albumin, it's drawn back into the vascular flow. And then any excess that doesn't get back in that way goes back to the venous flow through the lymphatic vessels. So looking at our diagram on the right, we have our red blood vessel and we have our blue cells, and the space in between is the interstitial area, that area between cells and vessels. What we can see there at the top is that our cell in A is our normal amount of water within the cell. So we get no net changes in movement between the fluid and the blood vessel and across through the interstitial tissues and into the cell itself. But in B, we're showing a cell that is deficient in water. And that means that as the hydrostatic pressure forces the water out through the vessel wall, it moves into the interstitial tissues, and it will then move into the cell in order to create the right concentration of proteins within the cell. If the cell becomes too large with fluid within it, then the water moves out of the cell back through the interstitial space and dilutes or maintains the albumin levels, concentration levels in the vessel itself, so that there's always this water movement stabilizing the normal fluid levels within the cell itself, maintaining the level of concentration of the proteins within the cell and the proteins within the blood vessels. Now you'll notice from the left that most proteins are within the cells, not in the interstitial fluid. So that means the water is going to go from the vessel where there's proteins, get forced out through the hydrostatic pressure, and then go to maintain the protein concentration inside the cell, because that's where the proteins are, these big molecules that don't tend to leave the cell. The other thing that is influencing this water movement is the sodium concentration, and the sodium concentration is normally in the interstitial fluid. It's on the outside of the cells. It's responsible for the extracellular osmotic balance. So the proteins within the cells keep the water balance happening inside the cells. The sodium keeps the water balance correct on the outside of the cells. And the thing to remember is that wherever sodium goes, water will go with it. The electrolyte that stays in balance with sodium is potassium. and potassium is always in balance on the inside of the cell, balanced with the sodium ion on the outside of the cell. And that means that we get a concentration for potassium inside the cell and a concentration for sodium and outside the cell that is maintained by the sodium-potassium pump. And of course that can be very important for those cells that have to create a depolarization for things like muscle contraction or for nervous signal message passing. If the total body water is too low, fluid moves out of the cells into the plasma, and that's because the albumin will stay within the vessels in order to maintain the fluid volume so that the heart has something to pump. And that means our cells would shrink in order to favour the fluid volume in the vessels. So the plasma volume is always maintained at the expense of the cellular volumes. The lymphatic drainage is there to turn around and move any interstitial fluid that can't get back into the vascular flow back to the venous flow through the lymphatic drainage. So if we lose fluid into the interstitial spaces, then we have the circumstance of edema. And if we look at the diagram on the right, it's got edema at the middle of the flowchart, and you can see on the bottom right hand side we have a lymphatic vessel either destruction or obstruction. That means that we don't get lymphatic drainage, so we get edema. On the bottom left hand side, if we've got increased capillary permeability such as in an inflammatory response, then we can lose fluid from the vascular space into the interstitial tissues, and so we see edema. If we look at the top part on the left hand side, if we've got increased hydrostatic pressure, so increased blood pressure such as in hypertension, then we can find that we lose more fluid into the tissues. If we have a lack of blood proteins so that we have a decreased osmotic pressure, then we fail to retrieve the fluid from the interstitial spaces back into the vascular space, and so we see edema. And so some of the reasons for those things potentially occurring are given to us in the list on the left hand side. Remembering that sodium, and wherever sodium's retained, water will also be retained. So renal failure can be a case of water retention, but also electrolyte retention. We've talked about congestive heart failure when we did the heart failure topic and how that can lead to edema. Venous obstruction is one we haven't spent much time talking about, and that can be the result of things like thrombus. But notice it also talks about lack of movement or prolonged standing. If you're the person standing behind the bar in an enclosed space and you're not actually walking much behind the bar, then you can find that your feet swell. If it's lack of movement, if you've sat on the plane from Sydney to London for that 23 or 26 hour flight, you can find that because the skeletal muscle pump is not moving as much as it normally would, the fluid's not being returned back up to the right side of the heart, and so you end up with fat feet. So if you made the mistake of taking your shoes off, you can find that you can't get them back on at the other end. Things like malnutrition can lead to a lack of plasma proteins. The liver's responsible for making those plasma proteins, so liver disease can lead to a decreased plasma proteins. If the glomerular filtration membrane is damaged so that there are large holes in the filter, then we can lose proteins out into the urine. Hemorrhage, because we're losing whole blood, so we lose plasma proteins. And burns, where those plasma proteins can be denatured and damaged. Now we have a picture on the right there of what's described as pitting edema, and if you can see the two depressions in the ankle joint there, we call it pitting edema because if you push on the swollen area it doesn't rebound. It basically just pushes the fluid around inside the interstitial tissue area, and it's very slow to come back to its normal shape. And that's often the case with things like right-sided cardiac failure. For that matter, it's one of those classic signs of right-sided cardiac failure. In terms of what happens with the tissues, whenever we have edema, that is fluid being retained in the interstitial tissues, then there's a much larger distance for nutrients and waste products to move from the vascular bed to the cells and back again. And that increases the risk for poor wound healing, for infection, and if it's occurring in the lungs, such as in pulmonary edema, then it increases the distance for gas exchange, which means that it's much harder to get CO2 out and O2 in to the blood, which is problematic. It'll cause shortness of breath and problems with breathing rates. Of course, you can see localized edema. Whenever we see trauma, we can see localized edema. We might see fluid collecting between the layers of the serous membrane, so the pleura or the pericardia, and or the peritoneum, which results in ascites. If it's more generalized, it could be the result of renal failure, so there's no one site where the fluid's collecting in. And when we talk about dependent edema, we're talking about fluid that's collecting in areas as a result of gravity. So if the person is horizontal, it might be in around the lower spine because they're bedridden. If you're sitting on the plane, it'll be your ankles because they're below the rest of the body. So that dependent edema, and of course the pitting edema is an example of a dependent edema. Now the thing to realise is that for every litre you store in excess, that's an extra kilo in weight you're carrying. And certainly if it's in around the joints, it will prevent movement, so you get that loss of function happening around the joints. And of course you get that visual puffiness if it's generalised. Now there is a circumstance that they refer to as third spacing, and this is where the fluid has moved out into the interstitial spaces, forcing the cells apart, and it's not a particularly easy spot for fluid to be retrieved from. So fluid movement in third spacing, in normal tissue the amount of fluid in the extracellular space is normal. In third spacing, you're seeing excess fluid in the extracellular space, which increases the size of the space. And that can result in circulatory shock, which we've talked about, and hypovolemia. Now there is a particular kind of edema called myxedema that's associated with low thyroid hormone as a result of a poorly functioning thyroid gland. So somebody with long-standing hypothyroidism can be seen to have this condition called myxedema, and it's where there's a large amount of protein and other water-binding substances have leaked into the interstitial space, and consequently they hold the water in the interstitial space. It can be particularly obvious around the eyes, certainly around the hands and feet, and you can see in the photograph on the right that very saggy sort of area around the eyes and on the lids. It's not boggy and it's not pitting like right-sided heart failure edema. And in fact the mucous membranes can actually thicken in this condition, restricting the larynx and the pharynx and changing the speech patterns and creating a hoarseness in the spoken speech. So myxedema is a special case of edema that we don't see very often because we're usually pretty good at diagnosing hypothyroidism and therefore correcting it by giving somebody thyroxine. Now we need to talk about the hormones that affect water balance, and we're going to start with antidiuretic hormone. And whenever the plasma concentration increases. So we have too much in the way of proteins, too much in the way of sodium within our plasma, then ADH will be triggered for secretion. There are osmoreceptors that detect that increased concentration of the electrolytes in the fluid that will send a signal to the brain to cause you to go and drink fluid and to release ADH to act on the kidneys to cause you to reabsorb water. So ADH is responsible for concentrating your urine, making the urine more dense by taking the water out of the urine and returning it to the body. So the flow chart on the right, we have this increased total plasma solutes that the osmoreceptors pick up in the hypothalamus that tells the posterior pituitary to release antidiuretic hormone, which tells the kidneys to retain water. So less water is excreted in the urine and more water retains in the bloodstream. And once the water is retained, we end up back with a normal plasma concentration of solutes and electrolytes. And that then switches the ADH release off. Now in the condition known as hypervolemia, we have somebody who has an excessive water intake that has increased their plasma volume, and that creates hypertension and may result in some bradycardia as a result of that because there's so much more fluid there for the heart to pump. But what it also does is dilute the sodium in the interstitial spaces, and that can be problematic for the sodium-potassium balance in order to do things like action potentials for cardiac conduction and muscle contraction. Water toxicity itself is fairly rare. There are conditions that can contribute to water toxicity. Compulsive drinking of water is one. Acute kidney injury is another. If there's poor renal blood flow, then we'll get decreased urine formation, and so that can be a circumstance that will contribute to water toxicity. Dextrose is a sugar, large molecule, so if somebody's giving an intravenous dextrose infusion, then if that's not monitored, that can lead to water toxicity. And then there is a condition called syndrome of inappropriate ADH secretion, where a person's pituitary gland is not controlling the ADH release. There are ectopic sites probably releasing ADH, which we mentioned when we talked about the neoplasia topic and how some tumours can release ADH. And so the feedback loop's disrupted. We get this inappropriate release of ADH, and that leads to increased water retention, and it's excess water that's not needed, so that can contribute to water toxicity and hypervolemia. So syndrome of inappropriate ADH secretion is contracted down to the letters SIADH. And what we're seeing are high levels of antidiuretic hormone without any normal physiological control. So the feedback loop is disrupted. And so we see more fluid being retained, which dilutes the sodium ion in the fluids. The most common cause of this is because of an ectopic production of ADH due to a cancer. But there are other causes. Aging, unfortunately, can result in this. Some of the antidepressant drugs or the hypoglycemic drugs can trigger this circumstance. There can be temporary SIDH because of surgical procedures that have caused fluid shifts. And the infectious pulmonary diseases, the lung tissue, infected lung tissue can start producing ADH. Now, hypovolemia, where we don't have enough fluid, tends to be the result of diarrhea. So we're losing huge amounts of fluid with the feces out through the bowel. Or vomiting. So we're losing fluid through the act of vomiting. You can see excessive sweating. But that fluid loss for any one of those reasons leads to hypotension, so low blood pressure, and the compensation effect of that is that the heart will try and manage the cardiac output by speeding up the heart rate. So in an otherwise healthy person, you will see them with tachycardia, and the definition of tachycardia, if you remember, was a heart rate of 100 beats a minute or greater. Now, another way that you can end up with hypovolemia is because of ADH deficiency. So there's not enough ADH in the system. Now this is fairly rare. It's called diabetes insipidus, and that's because when it was named, the similar sorts of symptoms occurred around polydipsia, so drinking lots, polyuria because of losing a lot of fluid in the urine, that led to dehydration that caused increased thirst and needing to drink more. And they're very similar symptoms to what you see in diabetes mellitus, but in diabetes mellitus it has to do with the sugar that's ended up in the urine that's acting as an osmotic draw, pulling more fluid into the urine that creates the polyuria and the polydipsia and the dehydration. Whereas in diabetes insipidus, it's that lack of antidiuretic hormones. So that without that ADH, the kidney doesn't get a signal to concentrate the urine and pull the water back from the filtrate so that it won't conserve water. Now, it can be because of a complete ADH deficiency, which we refer to as a neurogenic form of diabetes insipidus, or it can be nephrogenic. So the problem is actually in the kidneys because the kidneys are not responding to the ADH. So the ADH can be there, but the kidneys are ignoring it. And so we see neurogenic diabetes insipidus, or we see nephrogenic diabetes insipidus. Now, the reason that ADH is referred to as neurogenic, the absence of ADH, is because ADH is released from the posterior pituitary, but it's actually made in the hypothalamus. So the hypothalamus makes it, and then pituitary releases it. Now, the sorts of things that can cause the neurogenic form are tumours or trauma or surgery, whereas the sorts of things that cause the nephrogenic form are the renal diseases. Some drugs like lithium can have this impact, or the kidney itself is just completely unresponsive to the ADH. If it's a drug toxicity, it's usually reversible, fortunately. Now, in terms of fluid replacement, we need to remember that caffeine is actually a diuretic. And you might have noticed if you overindulge in caffeine and coffee, you find yourself in the bathroom far too often. Of course, overindulging in alcohol has a similar effect, and that's because alcohol inhibits antidiuretic hormone. So, they suggest that the morning after hangover after a big night on alcohol is partially due to the dehydration effect that inhibiting ADH has. You can see here that on the flowchart we're talking about dehydration as a decrease in body water, a decrease in blood volume, and that means the sodium concentration is raised, and so we have a higher blood sodium concentration, and the hypothalamus will pick that up through the osmoreceptors. Now that will stimulate ADH release, which targets the kidney to absorb more water, which causes less urine. So we've concentrated the urine and kept the water. That process increases the blood volume and decreases the concentration of sodium. So we come back to normal. Now, osmoreceptors, if they pick up that we're dehydrated, that would also cause us to be thirsty, and that will increase our fluid intake. But we do get a conscious choice of which fluid we take in. If it's water, then that helps contribute to the blood volume. If it's alcohol or coffee, we actually make the problem worse because we're inhibiting the action of ADH, and so we will keep losing fluid. If it's sugary foods, sugary drinks that we take in, we end up with much of that in our digestive tract. As I said before, glucose is a large molecule. Because it is a large molecule, that fluid will be drawn into the digestive tract, making for more fluid loss in the feces, which will have an impact on the sodium concentration, making again it worse. The other thing to realize is that if you have a lot of glucose in the system and you've overwhelmed the kidney's capacity to return glucose to the bloodstream, then the glucose will stay in the urine, and that will cause you to have more dilute urine. So you'll lose fluid that way as well. So it is important to understand the right fluid replacement to correct for things like vomiting and loss of fluids through things like vomiting and diarrhea, but also just on a daily basis to realize that you can make the dehydration worse by using alcohol and caffeine or sugary drinks as a mechanism of fluid replacement. So at this point we need to reintroduce the hormone aldosterone into our thinking, because aldosterone is all about sodium concentrations. Aldosterone will retrieve sodium, and by retrieving sodium it will also retrieve water, and ADH is only about the water, so ADH decides whether you will retrieve water or not. The thing about aldosterone though is that when you retrieve sodium you lose potassium. So whenever aldosterone is acting on the kidneys, we keep sodium, we keep water, but we lose potassium. Now that gives us the basis for the two diagrams below the flowchart there. On the left hand side we have sodium inside a cell for the normal sodium concentration. If we lose water, we end up with a higher sodium concentration. If we gain sodium, we end up with a higher sodium concentration, but we also start to retrieve water as well, so the cell will swell. On the right hand side, we're looking at a normal sodium concentration, but then a gain of water that dilutes our sodium. So this is what's happening in hypervolemia. But if we lose the sodium, we also lose the water. So that can mean that we end up dehydrated with less cell volume inside the cells. So in these graphs we're looking at hyponatremia, and you can see the signs and symptoms of acute hyponatremia at the top, where it starts out as thirst and impaired taste and fatigue, leading on to gastrointestinal symptoms such as vomiting and abdominal cramps that will eventually lead to confusion. Because you've upset the action potential, we'll see muscle twitching and seizures, and if it's acute enough and severe enough it can cause neurological damage. So it's a matter of putting back the sodium, so that means putting in some sodium chloride, and that will right the sodium concentration and send things back to normal. And it's preferable, of course, to make sure that you know what caused it so that you don't let that happen again. However, on the bottom with the red orangey chart, we're looking at a chronic condition of hyponatremia, and that's much slower to onset. The way they correct it is to restrict the fluid intakes so that that concentration of sodium comes back to normal. It certainly will start to show problems with lethargy and muscle twitching. If it hangs around for enough, there'll be some confusion and seizure. So you can see how dehydration can actually lead to an interpretation in our elderly of a certain amount of dementia. And it means that those symptoms don't usually become overly apparent as that being the problem until there's some substantial decline in the sodium levels. Now coming back to some revision around aldosterone, which is the hormone that's going to cause us to retain sodium, there are several ways in which aldosterone release is stimulated. One of those we've talked about quite a bit as part of the cardiac topic is the renin-angiotensin system. So whenever blood pressure starts to fall, the kidneys will release renin. That will cause angiotensin to go from angiotensin 1 to angiotensin 2. And angiotensin 2 does two things. It stimulates the adrenal cortex to release aldosterone so that we get sodium retention and water retention and therefore increased blood volume. But it also turns around and causes, it's quite a potent vessel constrictor, so that improves the fluid return to the heart, so that increases peripheral vasoconstriction and sends fluid back to the heart. But if it's not an issue of blood pressure dropping to the kidneys, then hyponatremia can cause aldosterone release, so that will turn around and cause the sodium retention. Hypocalcemia will also cause aldosterone secretion from the adrenal cortex, and corticotrophin releasing hormone will also cause the adrenal cortex to release aldosterone, so ACTH. Once aldosterone's in the system, we get sodium retention, water retention, and potassium loss. That brings increased volume into the blood volume, which increases blood pressure, and we get increased sodium within the blood. There are circumstances where we see excessive aldosterone in the system. There can be a primary hyperaldosteronism because of something like a benign adrenal adenoma that is releasing excessive aldosterone from the adrenal glands. In secondary hyperaldosteronism, the kidneys might be releasing too much renin, and it might be a sustained thing, or it might be a compensatory thing as a result of something like hypovolemic shock. The thing to remember is that if aldosterone is causing sodium retention, then it's also causing potassium loss. And so in hyperaldosteronism, where there's too much aldosterone in the system, we can see a condition where the patients end up with not enough potassium. And so the flowchart on the right is just putting that into a sequence for you. So at the top we have the causes leading to excessive aldosterone that act on the kidney, changing the concentration of sodium that is excreted, so that we see the sodium excretion decrease. That means we have more sodium in the plasma, and that will trigger renin to stop being released. However, increased extracellular fluid, which includes the plasma volume, will lead to hypertension, and that increased venous return that comes from that hypertension will increase the cardiac output, compounding the hypertension. The loss of this potassium as a result of the aldosterone being in the system will see a decreased potassium in the plasma. That generates vasoconstriction in the vessels. That improves the or increases the venous return to the heart, again increasing the cardiac output, because the more blood volume that goes into the chambers, the more stretched the chambers are, the harder they will contract, and that again adds to the hypertension. So this next flow chart starts to relate our problems around sodium concentration to our previous topics of heart failure. And you can see at the top there we're starting with the heart failure that results in a decreased cardiac output. Now moving round to the left hand side of the flow chart as you're looking at the screen, you get decreased blood pressure being picked up by the baroreceptors, and that will trigger increased secretion of ADH, which will trigger thirst, which will cause the kidneys to retain water, as well as increase the blood volume, plasma volume, through replacing water in the system. So you get increased body water and edema. But that increased fluid dilutes what sodium is available in the system. And if we go back to the top of the chart, where the decreased cardiac output means that there's decreased blood flow to the kidneys, the decreased cardiac output triggers the sympathetic nervous system to cause vasoconstriction at the kidneys. And that's because the heart's determined, well, the body is determined to make sure the heart has enough volume to pump, and it'll do that at the expense of blood flow through the kidneys. And so that decreased renal blood flow will see less renal water excretion, and that will also contribute to the water retained by the body. That excess water that's retained will dilute what sodium we have in the body, creating hyponatremia. Now, for those of you who are a bit challenged by your chemical symbols, just notice that when I've typed in hyponatremia, I've highlighted the Na as the chemical symbol in the middle of the word for sodium. And I've done the same thing here for hypo and hyperkalemia, where I've highlighted the K. The K is the symbol for potassium in the periodic table. Now, what we're seeing here are the diagrams for hypokalemia. And if we start at A, we have the normal intracellular extracellular balance, and the numbers are relatively arbitrary, but it is normal to have more potassium inside the cell than outside the cell, and that sets up a concentration gradient. So 12 potassium inside, 8 potassium outside. When we get to B, we can see that if we lose potassium from the extracellular fluid, that causes the concentration gradient to no longer be balanced, and so some of the potassium inside the cell will move out into the extracellular fluids. And so then we see that we now have 6 potassium ions sitting in the extracellular fluid, which is the fluid we can measure. And so we are now hypokalemic. Now, because of the action of aldosterone on potassium, we don't often see hyperkalemia. But if there is a contributor to hyperkalemia, it's usually because there's been some cellular damage that has released the potassium from inside the cell, where it's normally in the high concentration, to the extracellular space. So things like trauma and burns and crush injuries will cause that to happen. In acidosis, which we've looked at previously, hydrogen ions actually move into cells in exchange for potassium. Now that doesn't normally happen, it only happens in acidosis, and that returns the plasma pH to normal, but it can mean that we see too much potassium in the extracellular space. Other circumstances that contribute to hypokalemia is insulin. Insulin can promote cellular entry of potassium, and so if the insulin levels are low, then the potassium stays in the extracellular fluid, and diabetic ketoacidosis can occur with hyperkalemia. Renal failure can have this effect, so that the aldosterone can't act on the kidneys to cause potassium to be lost. The potassium sparing diuretics can cause too much potassium to be retained. And because digitalis, so digoxin, actually acts on the sodium potassium pump, if there's too much digoxin in the system, then it will actually inhibit the sodium potassium pump, and that can mean that the potassium stays in the extracellular space instead of going inside the cells. So in contrast, the contributors to hypokalemia tend to be things like dietary insufficiency in the elderly, alcoholism, anorexia, overuse of laxatives, diarrhea, or things like intestinal drainage tubes. The potassium wasting diuretics include furosemide. It inhibits sodium, increasing diuresis, which results in increased fluid flow rates through the tubules and increases potassium loss. Renal diseases that increase the speed of fluid through the kidney. So things like diabetes insipidus, where we're not concentrating urine and so there's a higher fluid loss. Some of the antibiotics can in fact increase potassium excretion. Magnesium deficits have been implicated in renal potassium excretion. And of course in respiratory or metabolic alkalosis, the potassium shifts into the intracellular space in exchange for hydrogen ion, and again that keeps the potassium, the plasma pH, normal, but results in hypokalemia as a result. The other way is to have an excess insulin intake that causes the sodium potassium pump to move too much potassium into the cells. Now, because those potassium concentrations have a role in the action potential, we see changes on the ECG in either hypokalemia or hyperkalemia. In hypokalemia with not enough potassium, we'll see evidence of a U wave on the ECG trace. So you can see in the middle diagram there where the T wave is a bit shallow and we have this second hump following it that is known as the U wave. Whereas in hyperkalemia we end up with these things called tented or peaked T waves. So the T wave is actually so much larger than it should be in terms of its amplitude, and can in fact be even higher than the QRS, the R wave peak. It'll also widen out the QRS width. So that brings us to calcium, which is our third electrolyte for the fluid and electrolytes topic. And we're only looking at the three of them, sodium, potassium and calcium. And we can see from the flowchart the feedback loop for maintaining blood calcium levels. The thyroid gland actually releases calcitonin, which stimulates the bone uptake of calcium so that the bones act as a calcium storage device. It's a negative feedback loop, so once the calcium is stored away, calcitonin will stop being released. The blood calcium through that action is decreased, and it is incredibly important that the blood calcium levels remain stable, because we use calcium for causing the nerves to release neurotransmitters. We use calcium for blood clotting. Calcium is also a trigger for enzyme actions inside cells. So calcium's levels need to be steadily maintained for all these functions. So if the blood calcium level is lowered back to normal, that's great. If the blood calcium is rising, then thyroid gland will cause it to be stored. If the calcium level is dropping, the parathyroid glands, which sit in the back, they're embedded in the back of the thyroid, they will have several actions when they're released. That parathyroid hormone causes the intestines to absorb more calcium. They cause the osteoclasts of the bones to release calcium from the bones, so bone breakdown. Parathyroid hormone will tell the kidneys to activate vitamin D, which increases our capacity for absorbing calcium from our food. And the kidneys themselves will start retrieving calcium from the filtrate, and all those things will work to keep the blood calcium levels normal. We also need calcium as part of our teeth matrix. We also need it as a mechanism for the actin myosin in our muscle cells to form the cross bridges for muscle contraction. And to end up with excessive calcium in the plasma, it's usually the result of too much parathyroid hormone being released, and that might be because there's an ectopic tumour making PTH, so that the feedback loop is no longer under that physiological control. Or there's an excess of vitamin D, so yes, you can have too much vitamin D. If there's bony metastases that are causing calcium release, so calcium resorption back into the plasma, that can also create problems with too much calcium in the plasma. Or hyperparathyroidism, so the parathyroid might have an adenoma in it that is releasing and making too much PTH. To end up with not enough calcium in the plasma, it can be a nutritional deficiency. It can be because there's deposition of calcium into the soft tissues, which we talked about in our cellular accumulations or cellular inclusions topic back with the material on cellular responses to stress and injury. Or it could well be that thyroid surgery, because the parathyroid glands are actually embedded in the back of the thyroid gland, they're actually quite difficult to see at surgery by eye. And that means they can be inadvertently removed when the thyroid gland is removed, and so there's no gland to make PTH. So this is a diagram of what's happening in hyperparathyroidism that's leading to hypercalcemia, and you can see some of the results here, that increased calcium ion and the increased PTH. We see changes on the ECG trace. We will see musculoskeletal changes. We will see muscle weakness because of its role in the cross-bridge formation. We can see things like renal stones because there's too much calcium being deposited into the kidneys and too much calcium in the urine. And it can actually lead to polyuria, so urinating far too often. It can cause problems with constipation. It can influence things like peptic ulcer. It can cause problems with pancreatitis because it can activate the enzyme pathways, and it can result in things like memory loss and confusion. So that brings us to talking about osteoporosis, which is a metabolic bone disease. And this is our example for this subject for metabolic bone disease. 1% of Australian males display osteoporosis, 3% of females, and it can be a matter of not having built enough bone density as a child and teenager, or it can be the result of aging where the hormone levels for estrogen and testosterone have fallen, and estrogen acts as a kind of like an assistant for calcium deposition into the bone. And so at menopause, women lose that estrogen level and it falls rather dramatically, and so they're at risk for osteoporosis thereafter. Andropause, being the male version thereof of menopause, is a much slower process. So as much as men do end up with osteoporosis, they don't end up with it at the same level as women do. Now, osteopenia is where we have low bone density. Osteoporosis is where we're actually seeing loss of matrix to the point where the bone is at risk of fracture. And if you look at the diagrams on the bottom there, where we've got the top row of compact cortical bone and then the spongy bone layer below, you can see how you're getting less and less and less actual bone matrix in either the compact bone or the trabecular bone. And that leads to the images we have on the top right of the screen, where the bone has very little density and it looks more like a gauzy spider web. So the pathogenesis, the development of osteoporosis, means that the tissue is mineralized but the density is decreased. And so in postmenopausal women, what we see is what we measure is the bone density of the postmenopausal women compared to a young female adult bone density. And from that, we can turn around and look at the risk for fracture. So if you go and have a bone mineral density study done, they'll come back and tell you how dense your bones are relative to a certain age group. So you might be as dense as, your bones might be as dense as a 19-year-old female, and then a measure of fracture risk coming back. So females post 50 years, the fracture risk is around 42%. Males, it's around 27%. So you can see that difference in menopause compared to andropause. Now the thing to remember is that day-to-day stress on bone actually causes the bone to be constantly remodeled. And so in our young years, we put down a lot of bone deposition, but it's peaked by the time we're 30. And at that point, our bone resorption to put calcium back into our plasma is greater than our actual capacity to deposit calcium into the bone mineral. That means that we essentially need to increase our physical activity, putting muscle stress onto the bone where the muscles attach in order to maintain that bone deposition. So you can see on the flowchart on the right that things like decreased sun exposure, where we have less vitamin D being activated, decreases our calcium intestinal absorption. Increasing age decreases our calcium absorption, and if we don't have enough dietary intake of vitamin D, that will decrease our intestinal calcium absorption. Now, as soon as we don't have enough plasma calcium, we will see an increase in PTH secretion, and as soon as we see that, we see increased osteoclast activity, which is the cells that are going to release the calcium from the bone, and so we get this excessive bone resorption in order to maintain the plasma calcium levels. Add into that a lack of estrogen at menopause, and so we have hypoestrogenism, and that means the osteoclasts aren't suppressed as much as they were, and the osteoblasts are in fact inhibited from creating bone deposition, and so we end up with a lack of bone density. Also notice that decrease in vitamin K intake, or our capacity to use vitamin K, can also impair the osteoblasts from depositing bone in the matrix, depositing calcium in the matrix. And if there's decreased secretion of growth hormone, or if there's anabolic steroids in the system, that can also create that, decreased anabolic steroids in the system, then that will decrease osteoblast activity. So we see bone loss. Now you can also see on the flowchart there that increasing inflammation will also increase the osteoclast activity, and some of that is about releasing calcium for the enzyme processes that are needed for inflammation and for the clotting factors as part of wound repairs and things. So lack of movement will actually decrease the amount of tension the muscles put on the bones, and so you will see a leaching of calcium out of the bones as such. So the chap who's just come back from an extended time on the space station, where there's no gravity to put that extra pressure on the muscles and the bones, would come back with some level of osteoporosis, and then he has to make that back up through physical activity upon getting back into an environment with gravity. So the x-rays there are giving you a sense of what it looks like to see osteoporosis. So A is just before a ligament reconstruction, and B is 2 months later after that reconstruction, and you can see the loss of density that's happening in around the wrist as a result of that lack of use in the intervening time of, you know, doing the surgical repair and healing and not using the hand. So osteoporosis is multifactorial. You get to your peak bone mass by about the time you're 30, and then it's a matter of the hormone changes, inflammatory changes, osteoclast activity that will contribute to the osteoporosis, and then of course aging with that decreased activity of the stem cells, decreased activity of the osteoblasts, and decreased biological activity of the matrix-bound growth factors, along with the steady decline in physical activity, and so we see osteoporosis. Okay, that's the last slide for this set.